Welcome to the deep dive. Today we're looking at a drug that was historically misused as a Cold War truth serum.
Right.
And it's literally derived from a plant called deadly nightshade. But, despite all that, today it happens to be one of the most purchased over-the-counter stomach cramp remedies in over 100 countries.
Yeah, it's why.
And somehow, despite that insane global popularity, it remains totally unapproved by the FDA here in the United States.
Well, that paradox is really the perfect entry point into our mission for you today. Because we are going into the fascinating and frankly, highly complex pharmacological world of antispasmodics.
Exactly.
Our goal here is to dissect this stack of pharmacological sources to understand exactly how these specific drugs manage to calm severe gut cramping and, why manipulating the human digestive tract is just fraught with so many unexpected consequences.
Right, because to really appreciate how bizarre the history and application of these drugs are, we need to start at the cellular level. Like when you tell someone you have a stomach cramp, when you're just doubled over in pain, what is physically happening inside the smooth muscle of your stomach or your colon?
Well, from a first principles perspective, that pain is, it's entirely driven by calcium.
Wait, calcium?
Yeah. The smooth muscle in your gastrointestinal tract relies on intracellular calcium levels to dictate its movement. So when the calcium concentration inside those smooth muscle cells spikes, it triggers this whole cascade involving an enzyme called myosin light chain kinase.
Okay, let's unpack this, because throwing out terms like, myosin light chain kinase can get a bit dense.
Fair enough.
Let's picture what the muscle is actually doing. We're basically talking about a microscopic tug of war, right? The muscle fibers, the actin and myosin, are grabbing onto each other and just pulling tight.
Exactly. That tug of war is the perfect visual. That is a normal contraction, which is what moves food along.
Right, but when it becomes sustained and forceful, that is a spasm.
Yeah, and calcium acts as the signal that, fires the starting pistol for that game. So if we want to stop a cramp, the entire pharmacological game is about preventing calcium from flooding the interior of that cell.
And the sources outline two primary pathways for this, right? Like two distinct doors that allow calcium to build up and cause this trouble.
They do. The first one is driven by your nervous system, specifically acetylcholine released from the enteric parasympathetic nerves.
Okay.
So this acetylcholine comes floating along and binds to these M3 muscarinic receptors on the outside of the smooth muscle cell.
And that binding is essentially like pulling a cellular fire alarm.
Pretty much, yeah.
Yeah.
It sets off a very specific internal chain reaction. If you look at the literature, you'll see terms like a GQ protein cascade, phospholipase C, and IP3.
Which, sounds like alphabet soup.
It really does. So let's break it down into, say, a bucket brigade.
I like that.
So the acetylcholine hits the M3 receptor on the outside. That receptor then hands a signal to the GQ protein just inside the cell membrane. Then GQ passes the bucket to an enzyme called phospholipase C, which synthesizes a messenger molecule called IP3.
Okay, so IP3 is the final step.
Right. IP3 is the final person in the bucket brigade.
Yeah.
That molecule actually runs deep into the cell and cracks open the internal vaults where calcium is stored.
Oh, wow.
Yeah, flooding the cell with calcium from the inside.
So if acetylcholine is pulling the fire alarm from the outside to release internal calcium stores, there has to be a way calcium just, walks right in from the outside environment too.
There is. The second route is entirely independent of neurotransmitters. The muscle cell membrane also contains these voltage-gated L-type calcium channels.
Okay.
When the electrical charge of the cell shifts, these channels simply open like floodgates, and external calcium rushes directly into the cell.
While I was going through these papers, I kept picturing this muscle cell as this really exclusive, high-stakes nightclub.
Okay, I can see that.
And calcium is this massive, rowdy crowd trying to get in to cause a scene, which is the cramp. So you have two doors into this club. Right. The front door is the M3 receptor, managed by acetylcholine and that whole bucket brigade. And then you have the side door, which is the L-type channel.
That's a great analogy.
Thanks. So to stop the cramp, antispasmodics have to act like bouncers blocking one of those specific doors. But the trick in the pharmacology is that a single bouncer can only guard one door at a time.
Exactly.
They block either the M3 door or the L-type door. They never block both at once.
And that mechanistic split is exactly why this whole drug class is pharmacologically divided. Because a specific molecule can only guard one door, pharmacologists split antispasmodics based on their target.
So who goes where?
Well, we have antimuscarinics guarding the front door
Oh, wow.
and calcium channel blockers guarding the side door.
But discovering how to block those cellular doors wasn't the result of some, like, high-tech, modern laboratory screening process.
Oh, definitely not.
This is where we get into the wild historical narrative. The ability to block the M3 door was basically discovered completely by accident in a hedgerow.
Yeah, the gastrointestinal antispasmodic effect was first exploited through plants in the Solanaceae family. We are talking about deadly nightshade, henbane, and jimsonweed.
I mean, just the names alone sound like a witch's brew.
They really do.
Deadly nightshade's botanical name is Atropa belladonna, and the sources note that belladonna translates to beautiful woman in Italian.
Right, because of the cosmetic use.
Yeah, women during the Renaissance would use drops of the plant extract to dilate their pupils, making their eyes look larger and more striking. Yet that exact same extract was being given to people to cure gut gripes and colic.
It's fascinating because early medicine relied heavily on utilizing a single pharmacological mechanism for wildly different endpoints way before anyone even understood what a receptor was.
Right.
These clans contain really powerful tropane alkaloids, specifically atropine and scopolamine. Scopolamine is also known as hyoscine, by the way.
Oh, okay.
By blocking those M3 receptors, the front door of your nightclub, they stopped both the pupil from constricting and the gut from cramping.
But relying on crude tinctures of a plant called deadly nightshade is obviously a massive gamble. Like, you can't control the dose, and the side effects are wildly unpredictable.
Totally. The shift toward modern safety finally began around 1880. A German chemist named Albert Ladenburg managed to isolate and characterize scopolamine from these plants.
Which was a huge step.
It was. It gave physicians a purified dosable compound. But scopolamine on its own presents a massive neurological problem.
Right, because, well, it doesn't just stay in the gut. Scopolamine crosses the blood-brain barrier.
That's it.
If you take it for a stomach ache, it enters the brain and causes profound sedation, confusion, and even hallucinations. This is the exact property that gave it that dark history as an incapacitating agent and an informal Cold War truth drug.
Yeah, which is terrifying.
You definitely don't want a truth serum when you just have food poisoning.
No, you really don't. And here's where it gets really interesting. The breakthrough to solve that problem happened in 1951. It was driven by chemists at a German company called Boehringer Ingelheim. They took Ladenburg's isolated scopolamine and deliberately altered its molecular structure.
How did they do that?
By quaternizing its nitrogen atom. Specifically, they attached a butyl bromide group to it.
This is such a brilliant piece of medicinal chemistry. By attaching that butyl bromide group, they gave the molecule a permanent positive charge. But why does a positive charge matter so much?
Well, we have to look at the physics of the blood-brain barrier. The barrier protecting your central nervous system is highly lipid. It's essentially a very dense, fatty fortress.
Right.
Molecules that are neutral and fat-soluble can slip right through it. But by giving the scopolamine molecule a permanent positive charge, the chemists essentially made it water-soluble.
Oh, I see.
Yeah, just as oil and water repel each other, this positively charged molecule physically bounces off the fatty lipid layer of the blood-brain barrier.
So it's physically trapped in the periphery of the body. It can only circulate in the gut and other peripheral organs.
Yeah.
So the central nervous system's side effects, the hallucinations, the heavy sedation, those are completely abolished because the drug simply cannot reach the brain.
Yep.
I mean, it's just such an elegant example of designing a drug to deliberately restrict its action rather than broaden it.
It really is. And that localized creation is hyoscine butyl bromide, which is commonly sold globally under the brand name Buscopan.
Right, Buscopan.
By successfully locking that M3 front door in the gut without affecting the brain, it reduces the amplitude and frequency of intestinal contractions. Today, it's used worldwide for irritable bowel syndrome flares, severe menstrual cramps, and infectious diarrhea.
Which is amazing.
It is. It's even given intravenously in emergency departments across Europe and Asia for excruciating conditions like renal colic.
Which brings us back to that bizarre regulatory quirk we mentioned at the start of the deep dive.
Oh, yeah?
Despite being one of the most widely sold over-the-counter medicines globally, available in more than 100 countries, hyoscine butyl bromide has never been approved by the FDA for sale in the United States.
And the source material is very careful to clarify that this is not a modern safety judgment by the FDA.
Right.
The drug has an incredibly strong safety record globally at oral over-the-counter doses. It's simply a historical and regulatory anomaly.
How so?
Well, it was developed in Germany in the 1950s and achieved massive global market saturation way before the modern, highly rigorous FDA approval gauntlets were fully established in the U.S.
Ah, I see.
And no pharmaceutical company has ever wanted to spend the hundreds of millions of dollars required to put this specific off-patent compound through contemporary FDA trials.
So if you're an American traveler, you might get a stomach bug in Latin America, walk into a pharmacy, and be handed this incredibly effective drug that you have absolutely never heard of.
Exactly.
Now, hyoscine butyl bromide handles the M3 door, but blocking that front door still comes with a cost because acetylcholine receptors aren't just in the gut, they're all over the body.
Yeah, that systemic issue is unavoidable with antimuscarinics. Even if the drug can't cross into the brain, it still travels through the bloodstream to other peripheral organs.
Right? So it will block the M3 receptors in your salivary glands, causing severe dry mouth. It'll block them in your eyes, causing blurred vision. And it'll block them in your bladder, causing urinary retention.
Which is why pharmacologists realized they needed a way to calm the muscle without touching the acetylcholine system at all. They needed to find a way to lock the side door, the L-type calcium channels instead.
And this drove a massive taxonomy shift in the 1960s and 70s.
Okay.
Up until that point, early pharmacology textbooks treated the term antispasmodic as pretty much synonymous with belladonna alkaloid.
Right.
But as synthetic agents emerged that targeted the muscle directly, pharmacologists had to draw a line between true anticholinergics and what they called musculotropic spasmolytics.
We should take a moment to bust a massive misconception here.
Good idea.
Because of that early history, there's an assumption among many patients and even some practitioners that all antispasmodics cause dry mouth and urinary retention.
Yeah.
And the sources make it clear that is completely false. It is a legacy myth. Roughly half of the clinically used antispasmodics today, drugs like mebeverine, alvarine, and papaverine, are musculotropics.
Meaning they act differently.
Right, they act directly on the muscle cells' sodium or calcium channels. Because they completely bypass the cholinergic receptor, they don't touch the M3 door. Therefore, those classic anticholinergic side effects are largely absent.
Now, when we talk about locking that side door, the calcium channel, there is one agent in the sources that I think will shock a lot of listeners.
Oh, definitely.
I know what you're probably thinking.
Yeah.
You can buy peppermint tea for $3 at the grocery store. How can an herbal candle scent possibly compete with the drug engineered in a multi-million-dollar pharmaceutical lab?
It sounds crazy, but peppermint oil is one of the most rigorously studied anomalies in modern gastrointestinal pharmacology.
It really is.
The active compound in peppermint oil is menthol. When it reaches the small intestine, menthol acts as a genuine, highly effective L-type calcium channel blocker. Yet, the pharmacological data shows its action at that side door is functionally indistinguishable from synthesized prescription calcium channel blockers.
It also stimulates something called TRPM8 receptors, right?
Yes, TRPM8 is a cold-sensing receptor found on sensory nerves in the gut. When menthol binds to it, it tricks the nerve into feeling a cooling sensation.
Oh, interesting.
But more importantly for a cramp, activating TRPM8 modulates the pain signals being sent from the gut to the brain, providing a mild local analgesic effect alongside the muscle relaxation.
And the clinical data backing this up is just staggering for a so-called natural remedy.
It is.
The sources highlight a 2019 Cochrane-related meta-analysis looking at irritable bowel syndrome, or IBS. They found that peppermint oil produced a number needed to treat, or NNT, of roughly 3 for global symptom improvement.
Right, and an NNT of 3 means that for every 3 patients treated with peppermint oil, one will experience a significant clinical improvement who would not have improved on placebo.
That's incredible.
In the realm of functional gastrointestinal disorders, an NNT of 3 is exceptional. It arguably outperforms several heavy-hitting prescription musculotropic drugs.
There is a very specific catch, though, regarding how you take it. You can't just drink a gallon of peppermint tea and expect this clinical result. It has to be in an enteric-coated capsule.
Yeah, precision delivery is the entire game here. Menthol is a powerful muscle relaxant. If a raw peppermint capsule dissolves in your stomach, it will relax the lower esophageal sphincter that's the valve separating your stomach from your esophagus.
Which sounds bad.
It is. Acid will splash up, and you'll experience intense, immediate heartburn. So the enteric coating is designed to survive stomach acid and only dissolve in the neutral pH of the small intestine, which is exactly where the cramping is happening.
Although the sources do gently point out a rather humorous side effect if the pill is poorly manufactured.
Oh, right.
If the enteric coating is too thick and it survives all the way to the end of the digestive tract.
Well, the literature describes it as rare anal or perianal burning.
Because the cooling effect of menthol is not particularly welcome there.
No, it's not. But it serves as a stark reminder that natural compounds invoke real receptor-defined physiological effects that really must be respected.
True. But an NNT of 3 for peppermint oil sounds phenomenal, which kind of opens up a broader debate. How well do the standard prescription antispasmodics actually work?
That's the big question.
We know they work flawlessly in a petri dish to stop a muscle contraction, but a human being is not a petri dish.
No. And the clinical efficacy debate is where the pharmacology gets messy. If we connect this to the bigger picture, IBS is the single largest indication for these drugs globally.
Right.
The sources heavily rely on major meta-analyses by Ford and colleagues from 2008 and 2014, which pooled dozens of trials pitting various antispasmodics against placebos.
And they found a statistically significant benefit, but the NNTs were hovering around 5 to 7?
Yeah.
That means you have to treat up to 7 people for one person to see a real benefit over a sugar pill. That's noticeably worse than the peppermint oil data.
It is. And critics of those meta-analyses point to severe limitations in the underlying data. The trials they pooled are often small, heavily industry-sponsored, and usually only last a few weeks.
Plus, didn't they mix everything together?
They did. The researchers threw all the drugs, the antimuscarinics, the musculotropics, the calcium channel blockers, into one massive statistical bucket.
Which seems scientifically flawed. If you have drugs working on completely different cellular doors, pooling their success rates together obscures whether one specific mechanism is far superior to another for a particular patient.
Exactly. And the heterogeneity of the data is exactly why major medical bodies, like the American College of Gastroenterology, have historically given antispasmodics only a conditional weak recommendation for IBS pain.
Wow.
The evidence just isn't robust enough to make them a universal gold standard.
So what does this all mean for the patient? This lack of a universal standard forces patients and doctors into a dangerous logic puzzle. It's something called subtype mismatch.
Right. IBS typically presents in two dominant forms: diarrhea predominant, known as IBS-D, and constipation predominant, known as IBS-C.
And antispasmodics fundamentally relax smooth muscle. They slow the transit of food through the gut.
Yep.
If you suffer from IBS-C, meaning your primary issue is that your digestive tract is already moving too slowly, taking a muscle relaxer to stop a temporary cramp could paralyze your gut even further.
Exactly.
You're basically trading a short-term cramp for long-term severe constipation.
It's a massive therapeutic trade-off. Providing blanket guidance that simply says, take antispasmodics for IBS is not just simplistic, it's potentially harmful if the mechanism isn't matched to the patient's specific motility profile.
Speaking of harm, we have to look at the most sobering failure mentioned in the source text.
Okay.
It's a tragic lesson in why we cannot casually assume that just because a drug relaxes a muscle, it's universally safe to use.
Yeah, the dicyclomine infant colic episode is one of the darker chapters in modern pediatrics. Dicomamine, which is often sold under the brand name Bentyl, is a classic antimuscarinic antispasmodic. In the 1970s and 1980s, physicians widely prescribed it for infantile colic.
And the logic seems sound on the surface. The baby is screaming because their stomach is cramping, therefore, give them a gut muscle relaxer to stop the cramp.
The initial logic was straightforward, but the clinical reality was terrifying. Case reports began accumulating of infants under 6 months of age suffering from apnea, literally ceasing to breathe.
That's awful.
Others were having severe seizure-like episodes. In rare but documented cases, infants died after receiving standard doses of the drug.
Why was an antispasmodic causing seizures and apnea in babies when adults take it every day without issue?
Neonates have incredibly immature physiological systems. Their blood-brain barriers are not fully formed, and their central nervous systems are highly vulnerable.
Oh, I see.
They prove to be disproportionately sensitive to the anticholinergic effects of the drug. Furthermore, dicyclomine possesses local anesthetic-like properties that adults can metabolize easily, but which caused a systemic overload in undeveloped neural pathways.
The fallout from that was a total overhaul in pediatric prescribing for this class.
It was.
Today, dicyclomine carries a strict absolute contraindication. It is never to be used in infants under 6 months of age. It's the ultimate cautionary tale about extrapolating adult smooth muscle data to neonates without dedicated safety trials.
It really reinforces the reality that manipulating neurotransmitter systems carries systemic risk. Even when we talk about hyoscine butyl bromide, the drug we praised earlier for being physically trapped outside the brain by its positive charge, it still poses systemic dangers in certain contexts.
Right, because peripherally restricted doesn't mean harmless. The sources note that when hyoscine butyl bromide is given intravenously in a hospital setting, it can cause transient tachycardia, a rapid racing heart rate.
Because the drug cannot enter the brain, but it circulates through the entire periphery, including the heart.
Ah, of course.
The vagus nerve normally acts as a brake on your heart rate, and it communicates using acetylcholine binding to M2 muscarinic receptors on the heart tissue.
Right.
The drug doesn't know the difference between the gut's M3 receptor and the heart's M2 receptor. It just blocks acetylcholine wherever it finds it in the periphery. So by blocking that vagal brake, the heart rate spikes.
This entire deep dive really reframes what's sitting on the pharmacy shelf. We started by looking at the microanatomy of a cramp, exploring how the M3 front door and the L-type side door allow calcium to trigger a muscle contraction.
We did.
We unpacked how chemists in 1951 brilliantly trapped scopolamine in the gut by giving it a permanent positive charge, creating a drug ubiquitous globally but completely ignored by the US FDA.
And we also dismantled the myth that all antispasmodics cause dry mouth and urinary retention, showing how musculotropics bypass that system entirely.
Exactly.
We elevated peppermint oil from a folk remedy to serious TRPM8 modulating pharmacology. And we confronted the stark safety limits of these drugs, from the therapeutic trade-offs in IBS-C to the tragic pediatric lessons of dicyclomine.
The sheer scale of this is why understanding this pharmacology matters to you. An estimated 10 to 15% of the global population has irritable bowel syndrome.
That's a huge number.
It's a staggering number of people dealing with disruptive daily gut cramping. And beyond IBS, these drugs are managing painful menstrual cramps, acute food poisoning, and even keeping the bowel perfectly still during delicate endoscopic imaging procedures. They are silently keeping the world functioning by managing an incredibly disruptive symptom.
Managing the symptom is the critical phrase here, because none of the drugs we discussed today cure the underlying problem.
Right. The sources make it clear that disorders like IBS involve profound gut-brain axis dysregulation, visceral hypersensitivity, and complex motility abnormalities. Antispasmodics do absolutely nothing to correct that miscommunication.
They are simply a temporary mute button.
So, we leave you with this final thought. If a severe gut cramp is effectively an alarm bell ringing from a highly dysregulated gut-brain axis, if it's an alarm bell, what vital information are we missing about our body's internal communication when our most successful pharmacological strategy is simply to smother the alarm?
It's definitely something to think about.
Thank you for joining us on this deep dive. Keep questioning and keep learning.